benchmarking findings, which are from our adults and older people's collection. So I'm going to pass over to Danny for this first set of findings.
Thank you, Emma. Hopefully I can take control. Yeah, okay, I've got it. So yeah, thank you very much, Emma, and good morning, everyone. My name's Danny Ioha. I'm a project manager here at the Benchmarking Network, and I lead the Adult and Older People's Mental Health Project. And I'm going to be presenting today the Adult and Older People's Mental Health 24-25 benchmarking findings. So just to give a bit of an overview and kind of the context of this project, this is the 14th year that the network has delivered the Adult and Older People's Mental Health Project. The project compares data across adults and older people's community and inpatient mental health services. And the data for this particular iteration of the project is for the 1st of April 2024 to the 31st of March 2025 reporting period. And bespoke reports were issued to each participating organisation at the end of October, and they are now available on our members area to download. In terms of the participation for this year's project, we received 75 submissions from 63 organisations, and that included 90% of mental health trusts in England, 71% of health boards in Wales, 80% of health boards in Scotland, and this was the 4th year of comprehensive participation that we had from the Scottish health boards, 1 health and social care trust in Northern Ireland, and we had participation from the states of Jersey and the independent sector again this year. And just to kind of preface the findings this year with some of the total figures across all community and inpatient services, just to give a bit of an idea of the kind of scale of what the data represents that you're going to be seeing. In community services, there was just over 2.5 million referrals received. There was just over 813,000 service users on the caseload at the year end, at the reporting period year end on the 31st of March 2025. There were just over 15 million contacts delivered into community services. And in inpatient care, there were just over 93,500 admissions to inpatient care and just over 21,500 total beds at year end at the 31st of March 2025. This next chart is showing the balance of care in terms of expenditure across community and inpatient mental health services. And it shows the split of expenditure for kind of each organisation in the sample. This data does include specialist services. It's a totality. And we can see the average split of expenditure was 53% to community services and 47% to inpatient services. And this was a 2% increase of expenditure on community services compared to the 2023-24 data, which does align with the kind of the vision of the long-term plan with the government's focus on services being provided more in the community. This year, there was a particular focus on productivity and financial sustainability across our entire member programme. And I'm just going to share some of the findings from some of the new metrics we brought in this year in these areas into the Adult and Older People's Mental Health collection. One of the key productivity metrics that we report on is contacts delivered per clinical whole-time equivalent per day. And we do scale this down to each working day. And we can see the metric in the chart on the left here, with the sample median being 2 contacts delivered per clinical whole-time equivalent per day in 2024-25. And on the right is the associated cost of these contacts, with the median being reported as £241 per contact, which was a £24 decrease on last year, which ended an increase in the cost of 1 contact that we saw year on year since 2021-22. Here we can see the same metrics, but for older people's community teams. We do see a slightly lower number of 1.6 contacts delivered per clinical whole time equivalent per day. And unlike generic community mental health teams, older people's community teams reported a notable increase to £311 per contact, which continued an increase year on year since 2021-22, and showed a total increase of £84 per contact over the last 4 years. The lower contact rate per whole time equivalent may reflect a deliberate focus on delivering more kind of comprehensive person-centered care rather than high volume activity. And the increase in cost per contact may reflect inflation or the fact that older people's teams may operate with different priorities, such as home visits, carer support, or safeguarding, which are more time and kind of resource intensive, which may lead to higher costs of each contact. In both generic community mental health teams and older people's teams, around 2/3 of contacts were delivered face-to-face. Compared to last year, we actually see that face-to-face contacts in generic community mental health teams were down 1%, with digital or video contacts being up 1%. And this was the first time we've seen the contact method move back towards digital contacts since the pandemic, albeit a very kind of marginal shift. However, in older people's community teams, we do see face-to-face contacts increasing by 2%, with telephone contacts decreasing by 1%. This could be a positive trend, as it could suggest an improvement in accessibility to in-person community services for older people. The average time spent on caseload was another new metric that we introduced this year for the adult and older people's mental health collection. So while we don't have a kind of year-on-year comparison, we can compare across teams, and we do see a lower average time on caseload for older people at 30 weeks compared to 40 weeks in generic community mental health teams. The figure for generic community mental health teams is actually more in line with some the specialist kind of higher acuity community services such as forensic teams and early intervention for psychosis teams. They both reported a median of 42 and 44 weeks, respectively. So it does raise the question as to why the figure for generic teams sits where it is and isn't more in line with the older people teams, and perhaps implies that generic community mental health teams are perhaps supporting individuals with maybe significant long-term mental health needs, possibly including psychosis or personality disorders. Service users perhaps aren't being dealt with in the appropriate teams. A metric that we introduced in last year's collection was the re-referral rate. This is defined by the total number of service users previously on caseload and were then re-referred back to the service in 2024-25 within 12 months of them being discharged. And that is re-referred back to community services as a whole, so it doesn't necessarily have to be the same specific team. And we show this as a proportion of the total number of referrals. In 2023-24, the median re-referral rate was 23% in both generic community mental health teams and older people's teams. And in 24-25, we saw a decrease in both teams, most notably in older people's teams, which decreased to 15%, while in generic community mental health teams, the rate decreased to 21%. A reduction in re-referrals may reflect more effective treatment, better recovery planning, and stronger support systems that help patients maintain stability post-discharge. And it may also suggest that teams may be implementing more robust discharge planning and clearer follow-up pathways. One of the areas that we kind of identified as potentially being able to kind of indicate potential cost-saving opportunities for organisations is in did not attend. Emma, I've just seen a comment there. Are we going to?
Yeah, are we okay to pause here,
Absolutely.
Danny?
Yeah.
Yeah, we will. We were hoping it was going to be in the middle of 2 sessions, but we're slightly ahead of time. So as soon as my clock turns 11, we will just pause for 2 minutes, if that's okay with everyone. Um, there we go. Thank you. Okay, thanks everybody. Danny, I'll hand back over.
Thank you, Emma. Okay, I'll start this slide again. So yeah, as I was saying, one of the areas that we kind of identified potential well that we identified that we could maybe indicate some potential cost saving opportunities was in did not attend or DNAs. Again, this was the first time we included it in the adult and older people's mental health collection this year. And here we're looking at the proportion of DNAs compared to the total number of appointments. In generic community mental health teams, the median DNA rate was 10% or 1 in 10 appointments, and the median cost per DNA was reported as £223. Do bear in mind that there can be kind of variance between the cost of each appointment, and this is just an average cost of all appointments. This year, we also looked at the median overall cost of DNAs for each organisation, and this was reported as £2.5 million per organisation, which again just highlights the kind of impacts that reducing DNAs would have in terms of costs. In older people's teams, the data showed a slightly different story, with a notably lower DNA rate of 2.3%, while the associated cost of each DNA was notably higher at £284 per DNA, and this is due to the kind of higher overall cost of older people's services compared to the lower number of appointments. However, because the rate is notably lower than in generic community mental health teams, the overall cost of DNAs was also lower at £0.2 million per organisation. So again, just kind of evidences the impact of a lower DNA rate on total costs. Another area of focus for this year's collection was health inequalities across community and inpatient mental health services. And I'm just going to take you through some of the findings of the demographic data that we collected this year. Looking at the national ethnicity breakdown of community mental health services compared to the UK population, 16% of community service users had an ethnicity reported as not known or not stated. This was 2% less than last year, so a kind of a positive trend towards having more demographic data known and available. However, it is still a notable proportion of the entire data set, and does make the comparison to the UK slightly less reliable. What we can see in the data is that there was a marginal overrepresentation of mixed ethnicities and an underrepresentation of Asian British ethnicities on community caseloads compared to the national data. When we look at inpatient mental health services compared to the UK population, we see there are 7% more detentions of ethnic minorities compared to admissions. 1% more, this is 1% more variance compared to last year's data. And when we look a bit closer at the ethnicities of inpatient detentions, there is a 6% overrepresentation of Black or Black British individuals compared to the background UK population. And this was the same variance that was reported last year. Looking at the ethnicities in a bit more detail at the community team level, we see an overrepresentation of ethnic minorities in the areas of highest acuity. So this includes assertive outreach teams, early intervention for psychosis teams, and forensic teams. And looking a bit closer, the most notable overrepresentation is of Black or Black British individuals on assertive outreach teams, which was 18% compared to 4% of the background population. In contrast, we see an underrepresentation of ethnic minorities in assessment and brief intervention, older people's teams and neurodiversity teams compared to the background population, which could suggest potential systemic factors influencing service engagement or perhaps creating barriers to referral pathways. In terms of inpatient services, again, looking at the data in a bit more detail at the kind of service level, there was an overrepresentation of ethnic minorities in PICU and secure services, which is a continued trend that we see year on year. And again, kind of highlights the potential systemic factors and biases causing the disproportionate number of ethnic minorities being referred from criminal justice pathways. And there was also an underrepresentation of ethnic minorities in older adult, longer-term or complex care, neuropsychiatry and substance misuse services, which again raises the question of equity or equity of accessibility to these services for all ethnicities. The gender split across all community services was 55% female to 45% male, a much higher representation of females when compared to inpatient services. However, this was 1% fewer females and 1% more males when compared to 2023-24 in community services. When we break it down further again to the community team level, we see an overrepresentation of males in forensic services and of females in eating disorder services, although the proportion of females on eating disorder teams did decrease by 2% compared to the previous year and 5% from the year prior. We also see a 6% higher representation of females in older people services compared to generic community mental health teams. The gender split across inpatient services was 47% female to 53% male, which was in line with the previous year. When we break it down further to the inpatient service level, again, we see an overrepresentation of males in secure services and of females in eating disorder services. And again, there is a higher proportion of females in older adult services compared to adult acute. However, there is more of a balanced proportion of males to females in inpatient services compared to community services across working age and older age adults. I'm now going to focus on community services, looking across activity, workforce, and finance data for both generic and specialist community teams. This chart shows where the kind of demand is coming from in regards to referrals to community services. We can see that generic community mental health teams make up just over 1 in 5 referrals, with just over 1 in 6 referrals going to either older people's teams or memory services. We also see quite a notable proportion of demand coming from assessment and brief intervention teams, as well as crisis resolution and home treatment teams, mainly due to the services having kind of a quick turnaround, with patients not staying on caseloads for very long, allowing for a kind of higher referral rate. Looking at waiting times for each community team, this chart shows the median patient wait from referral to second appointment, but we kind of have split that into referral to first appointment in blue, and then first to second appointment in orange. In generic community mental health teams, there was a decrease of 1 week for waiting times from referral to first appointment compared to 23-24, which resulted in a 0.9-week decrease from referral to second appointment. There was also notable decreases from referral to second appointment of 1 week in individual placement and support services, 1 week in older people's teams, and 1.4 weeks in memory services. The neurodiversity services saw quite a bit of variance compared to the previous year, with a 38.9-week increase in autism spectrum disorder waits to second appointment, and a 30-week increase in ADHD teams. Other neurodiversity services saw a 38.7-week decrease. However, the sample size for this was relatively small, and perhaps less reliable due to that as kind of a national indicator. In terms of referrals received into generic community mental health teams across 24-25, there was an increase in demand this year, which kind of reflects what Kadra was saying earlier in her presentation. And the sample median per 100,000 population was reported as 1,801 referrals. This was a 15% increase on last year, and continues a year-on-year increase that we've seen since 2021-22. The referral acceptance rate, however, remained at 86%, which suggests the number of referrals being accepted kind of increased in line with the increase in demand. And the rates over the last 2 years were also kind of marginally higher than the previous 2 years, by 1%. In generic community mental health teams, the median caseload per 100,000 population at year end, so the 31st of March 2025, was 1,028. This again reflects an increase compared to previous years, around 200 service users larger than 4 years ago, and was a 14% increase on last year's median caseload. The number of contacts per 100,000 population also saw a sharp rise at just over 17,000, which was a 15% increase compared to 2023-24, after the previous, or the 3 years prior, remained relatively stable. When we look further back, we can see the activity levels reported in generic community mental health teams in 2024-25 did return to the levels that we saw during the pandemic for the first time since the pandemic. And if you just think back to the previous slide on referrals, you may have noticed there is kind of a pattern of around a 14 to 15% increase in demand and activity in generic community mental health teams compared to last year. If we look at the generic community mental health team staff skill mix and staffing levels that are employed to kind of deal with this increase in demand, the nursing and clinical support complement was exactly half of the total staffing complement, which was a 1% increase compared to 2023-24. Staff in psychological professions made up 17% of the workforce, which was a 2% increase compared to 2023-24. While we saw that staff in administration and management made up 14% of the workforce, which was actually a 2% decrease compared to last year. If we look at the staffing levels on generic community mental health teams, the median whole-time equivalent per 100 patients on caseload this year was 4.2 WTE. And this was a decrease of 1 full whole-time equivalent per 100 patients compared to 23-24. And this can largely be put down to the increase in caseload that we saw on the previous slide, while the number of staff employed to deal with this has not increased proportionally. The median staff vacancy rate in generic community mental health teams was 11%, which remained in line with last year and was 1% lower than the previous 2 years. And the median staff sickness absence rate was 6%, which was a 1% increase on last year's rate, although this has kind of remained relatively stable over the last 4 years. The spend on bank and agency staff in generic community mental health teams as a percentage of total pay costs was 8%. This was a 3% decrease from last year and is the lowest it's been since 2021-22. And this indicates a move to more substantive staff in 2024-25. And when we look at patient costs, the total cost of generic community mental health teams per patient on caseload was £4,511, which was a £235 increase per patient compared to 2023-24, and it was a return to the 22-23 figure. I'm now going to talk through some of our inpatient metrics, looking across, again, activity, workforce, and finance data for both general and specialist inpatient services. The inpatient bed profile this year saw adult acute services accounting for just less than 2 of every 5 inpatient beds, with older adult services accounting for just over 1 in every 5 beds. There was a 2% decrease in the proportion of inpatient beds that were adult acute, while there was a 2% increase in the proportion of secure beds. Looking at the bed occupancy for each inpatient service, adult acute beds had a 95% occupancy rate, which was a 1% decrease compared to 23-24. Other kind of notable changes were seen in high dependency rehabilitation beds, which reported a 93% occupancy rate, and that was a 4% increase on the 23-24 figure. Low secure beds, which reported an 87% occupancy rate, was a 4% decrease on 23-24. And longer term complex and continuing care beds reported an 83% occupancy rate, and this was a 5% decrease on 23-24. The nationally recommended threshold for occupancy rate is, I believe, to 85%. And we can see that 6 inpatient services are currently above that threshold. And adult acute, which is the service with the largest bed base, also has the highest occupancy rate. And this pattern could indicate that a kind of existing bed capacity is insufficient to meet the current demand in the most used services. This chart shows the median length of stay across the various inpatient services that we collect. What we can see in the table on the right is quite a lot of variance in the length of stay changes compared to last year. The most notable being in secure services, with low secure services reporting a decrease in length of stay of 58 days, while medium secure services reported an increase of 93 days. Longer term complex and continuing care services also reported a decrease in length of stay of 57 days, while adult acute and older adult services remained relatively stable, not changing by more than 1 week either way. The median number of adult acute beds at year end per 100,000 population was 22. This was in line with last year and the year before, and remains higher than the 21-22 figure. And as we saw earlier, the median bed occupancy rate for adult acute beds was 95%, which, while being a 1% decrease on last year, is still higher than the previous 2 years of 93 and 94%. Here we can see the adult acute admissions, and the median number of admissions across 24-25 per 100,000 population was 185. This was a decrease of 10 compared to 23-24, and continues a decrease in admission rates that we've seen since 22-23. This decrease in activity is kind of the opposite of what we saw in community, and again kind of indicates that national drive to move to more community-based mental health care. We can see that that's beginning to take effect. When we look at the proportion of adult acute admissions reported under the Mental Health Act, the median was reported as 55%. This was a 6% increase on last year, and it's actually the first time in 4 years that more than half of all admissions were detentions at the point of admission. And this could suggest that individuals are reaching services in more severe states of crisis, possibly due to delays in early intervention, and it could imply that fewer people are accessing inpatient care voluntarily, which may point to issues of kind of trust, stigma, or possibly accessibility within the system. These charts show the kind of status of patients being admitted to adult acute services. The median proportion of adult acute patients that were not previously known to the service was 6%. This was the lowest rate in 4 years, and continues a gradual decrease that we've seen year on year since 2021-22. A lower proportion of new patients may reflect a growing number of individuals kind of experiencing recurring or chronic mental health crises that require inpatient care, but could also suggest better continuity of care with improved identification and tracking with the knowledge of who the patients are across services. The median proportion of adult acute patients that had no fixed abode at the point of admission was 2.4%. This was actually the highest rate in 4 years, and continued a gradual increase that we've seen year on year. A higher proportion of patients with no fixed abode reflects perhaps worsening social determinants of health, particularly housing insecurity, which can exacerbate mental illness and limit access to preventative care. Individuals without stable housing also might face challenges accessing mental health services, which can lead to more frequent kind of crisis-driven admissions, which we saw is perhaps reflected in the increase in the secure service bed base we saw earlier. A lack of stable housing also creates barriers to discharge and can result in delayed discharges, which can add more pressure to services as well. Now, if we look at the adult acute staff skill mix and staffing levels, the nursing complement was 38%, which was a 2% increase on 2023-24, while the number of clinical support staff decreased by 3% to 45%. In other areas, staff in administration and management increased by 2% to 5% of the total workforce, while medical staff decreased by 1% to 5% of the workforce. If we look at the staffing levels in adult acute services, the median whole-time equivalent per 10 beds this year was 20 WTE. This was a decrease of 1 full whole-time equivalent per 10 beds compared to 2023-24, and continued again a gradual decrease over the last 3 years. And unlike in community services, this trend is more in line with the decrease in activity that we saw earlier in terms of admissions. Looking at the vacancy rate in adult acute services, the median was 14% this year, which was a 1% increase on 23-24. However, it's still notably lower than the 21-22 rate of 18%. And the median staff sickness absence rate was 7%. Again, as we saw in community services, this has remained relatively stable over the last 4 years, and it is about in line with what we saw in community services. The median spend on bank and agency staff in adult acute inpatient services as a percentage of the total pay costs was 28%. This was kind of similar to what we saw in community, a notable 5% decrease from last year, and again is the lowest that it's been since 2021-22, and again possibly indicating a move to more substantive staff this year. And when we look at the patient costs, the total cost of adult acute services per 10 beds was £2.3 million, which continued a gradual increase in costs year on year and is just under £500,000 higher than the figure in 2021-22, which again could be put down to general inflation. And this data doesn't kind of factor in that general inflation in itself. It is just the raw data. But it could suggest an increase in complexity of care, such as patients presenting with comorbidities, and may also suggest longer lengths of stay, driving up per bed costs. So now to look at some of the key metrics for older adult inpatient services. The median number of older adult beds at year end per 100,000 population was 35, which was in line with last year, but it does remain lower than the 2 years prior. And this figure is also notably higher than the adult acute figure of 22 beds per 100,000 population. So although adult acute services has a larger bed base, it's actually lower when you compare it to the background population. The median bed occupancy rate for older adult beds was 91%, which was a 1% increase on 23-24, and continued a gradual increase over the last 4 years of 4% in total. Again, kind of moving further away from that recommended threshold of 85%, and could indicate that older adult inpatient services are operating under kind of sustained and increasing pressure, with more limited bed availability, which can leave little flexibility for kind of urgent admissions or transfers, and could potentially compromise patient safety and care quality. While the number of adult acute admissions decreased in 24-25, we actually saw the number of older adult admissions increase by 5%, to actually back to the 21-22 levels after a gradual decrease that we saw over the kind of 3 years prior. So the shift towards community-based kind of mental health care appears to be yielding kind of greater impact for working age adults compared to older aged adults. We see that shift a bit more in the working age adult population. When we look at the proportion of older adult admissions reported under the Mental Health Act, the median was reported at 67%, which was a quite large 7% increase on last year, similar to the pattern that we saw in adult acute services. And again, the rate was the highest reported rate that we've seen in 4 years. And again, this may suggest that older adults are kind of reaching services in more advanced stages of illness, perhaps with severe dementia or psychosis, where kind of compulsory admission becomes necessary. Looking at the status of the older adult patients being admitted to the services, the median proportion of adult acute patients that were not previously known to the service was 8%, which was a 1% increase on 2023-24. However, it does remain lower than the 21-22 figure. The median proportion of older adult patients that had no fixed abode at the point of admission was 0.7%. Around a third lower than adult acute services, and this is actually the lowest rate in 4 years. And this could reflect the kind of greater kind of housing stability among older adults, and the decline over 4 years could also reflect successful local or national efforts to kind of address housing insecurity among older adults, such as supported housing schemes or perhaps safeguarding initiatives. In terms of the older adult staff skill mix and staffing levels, this did remain more stable compared to the previous year, compared to the other services that we've seen today. The nursing complement was 35%, which was a very marginal 1% increase on 23-24, while the number of clinical support staff decreased by 1% to 52%. In other areas, medical staff increased by 2% to 5% of the workforce, with both allied health professionals and staff in psychological professions increasing by 1% to 3% and 2% of the workforce, respectively. If we look at the total staffing levels in older adult services, The median whole-time equivalent per 10 beds this year was 24 WTE, and this has remained relatively stable over the last 4 years. However, we do see 4 more, if you think back to adult acute, we see 4 more whole-time equivalent staff per 10 older people beds compared to adult acute. Looking at the vacancy rate in older adult services, the median was 9% this year, which was actually a 4% decrease on 23-24, and is a notable decrease compared to the last 4 years. A 4% drop in vacancies could reflect successful efforts to attract and retain staff, such as maybe targeted recruitment campaigns, perhaps better working conditions or career pathways as well in older adult services. It's also in line with the kind of lowered reliance on bank and agency staff that we'll see on the next slide. And it could also help to ease pressure on existing teams. The median staff sickness absence rate was 8% in older adult services, and this has again remained relatively stable over the last 4 years, and is in line with the rate for adult acute services and what we saw in community services. Again, looking at the bank and agency spend as a percentage of total pay costs, this was 23% amongst the sample, and this was again a notable 4% decrease from last year. And again, not to kind of sound like a broken record, but highlighting that move to more substantive staff that we've seen across all services. The rate is also 5% lower in older adult services compared to adult acute. Perhaps older adult services may kind of operate within with different service models, such as longer term care, that tend to kind of lend themselves to more permanent staffing arrangements. This is a positive, as a kind of a stable team can improve therapeutic relationships, which is kind of especially important for older adults that have cognitive impairments or complex needs. When we look at patient costs, the total cost of older adult services per 10 beds was £2.3 million. And like adult acute services, this continues a gradual increase in costs year on year. And again, is around £500,000 higher than the figure that we saw in 21-22. Other than a result of inflation, which could very well be the reason, this rise may also be a result of pressures caused by the higher admission rate, but may also reflect efforts to reduce vacancy rates, as relying less on bank and agency staff can enhance care quality, but it does also raise expenditure. And finally, I'm just going to touch on the Equally Well UK pledge that Kadra touched on earlier. It's run by the Centre for Mental Health, and also look briefly at the use of outcome measures, which we collected this year. In terms of the Equally Well pledge, out of 42 responses, 29% reported having signed up to the pledge, and this was a 5% increase on the previous year. And out of 59 responses, 93% reported using outcome measures, which was in line with the figure for last year. And we saw the most commonly reported PROMs and PREMs across organisations were the Recovering Quality of Life measure, the dialogue scale, and the core outcome measure tool. And I believe that's the end of the findings presentation. Sort of finished slightly earlier than planned, but I think because we started slightly earlier than planned. If you do have any questions, please, there is a bit of time now to ask, or you can also put them in the chat. Someone in the team or myself will be able to answer the question there. Just to say as well, as always, if you'd like to look in more detail at the full data set for adult and older people's mental health, do your own analysis, do head to our online toolkit on the members area, which does contain the kind of full data set. And for any further information about the project, please get in touch with me, and you can see my email on the screen there. So thank you very much, everyone, for listening, and I'm going to hand back over to Emma.
Lovely, thanks, Danny. There were a few comments in the chat. If anyone does want to raise their hand and ask a question themselves, please do that. Like Danny said, we have got a few minutes to take some questions. There were a few comments earlier on in the session around the productivity metrics in particular, just in terms of some of the methodology. And I think from my perspective, this is an area that we are trying to develop and support organisations with. So any comments or thoughts in terms of what's useful or how we can improve those measures are really, really welcome. I think it's fair to say at the moment they're fairly crude measures in terms of how we're presenting those productivity type insight. But again, like I say, an area for us to develop. Danny, I don't know if you have any other thoughts around any of the productivity or the health inequalities in particular.
Um, I'm going to get through the questions. I'll probably get back to them in the chat for a more kind of thorough, after I have a thorough read of the questions. I can see a few kind of dotted around, but I will get back to those in the chat.
Lovely, thanks, Danny. And like Danny said, the full data set is available on our members area if you want to dig into all the different team types in a lot more detail, as well as being able to access your individual organisation's report. Or did I see a hand up then? Maybe, maybe not. Okay, I will move us on then. Thank you, Danny. Thanks, everybody. Our next session is around the NHS Benchmarking Network's workforce programme. So I'm going to hand over to Janet for the next session. Thanks, Janet. Oh, you're on mute, Janet.
Typical. Thanks, Emma. I'll just take control of the presentation and take it from here. Can everybody see the slides?
Yes.
Great, thank you. Okay. So I'm going to just do an overview of the NHS Benchmarking Network's workforce programme. Ultimately, benchmarking the healthcare workforce ensures the right people are in the right place, in the right number to meet the population needs. Benchmarking helps to ask the questions of the service. For example, where are services overstaffed or understaffed? Are services aligned to their skill sets, and are our staff suffering from burnout and not staying within the profession? And it's time for a recruitment drive or providing more opportunities to upskill staff. In the next few slides, we will show some of the outputs we produced from the previous workforce census collections and explain how this data can help to make staffing levels safer and meet population needs. I'm aware that a number of people on this call today will be fully aware of our workforce programme, and I'd just like to thank you for all your participation in our various projects. I appreciate that they are extensive, and the data that we collect is at a very granular level. So that our current set of workforce census collections is done in collaboration with the NHS England Workforce Training and Education Directorate. We work directly for them to produce the data that they require. And you can see on the infographic on the right hand side of the page highlights the key ways that workforce benchmarking is used to support workforce planning, and it can support you as well, and I'll go through each of these with a bit of data to help expand on this further. So for workforce planning and retention, we identify trends in staffing levels and retention to inform your decision making, productivity, comparing to skill mix to enhance efficiency. With staffing levels, we have the ability to benchmark against peers to ensure a safe and effective workforce. And we analyse sickness rates to identify workforce challenges and planning for future staffing needs based. This is just an infographic on what we delivered in 2024. We collected just under 1 million data points across a variety of sectors, so we do hold a very comprehensive data set. We produce a national report per data collection, and we also produced participant reports and ICS reports for each of the data collections. If you've noticed the asterisks against the participation and ICS reports, it's because we've got some new technology coming this year that will replace these reports in the upcoming cycle of workforce collections. So I'll move on to now to how we are supporting safer staffing in 2025. We're currently collecting workforce data with NHS England, as I said, and we are working in 6 sectors. It's not the limit of what we can do for the workforce census, it just gives an idea of the range of projects that we're currently running. So we are looking at psychological professions, talking therapies for anxiety and depression, peer support workers, and we also do the children and young people's mental health and the adults and older people's mental health in conjunction with the member programme. And new for this year is learning disabilities and autism, and that's currently in data collection at the moment. So please contact the team if you need any help with the learning disability and autism collection. I'm just going to move on to some of the outputs from 2024. The first example is on workforce planning and retention in the talking therapies data collection. And this data represents the national picture. In dark blue, we have the staffing levels for non-clinical and clinical workforce between 2019 and 2024. The percentage between the years indicates the change between years, and you can see the overall growth in the workforce year on year. We can dig down a little deeper and look at the same year-on-year workforce levels for high intensity and low intensity, and those are in the lighter blue and green lines on the charts. This also shows us a year-on-year growth, and the largest between 2020 and 2021. Identifying trends in the staffing levels helps us to inform decision making, but what this data helps us to prompt is important questions such as is the growth and change in line with current guidance and healthcare policy? Is the growth might be in an upward direction, but is that in line with targets and population needs? And are the workforce levels rising in line with demand? Workforce growth is often highlighted as being a good thing. However, is it in the right areas, and is it where we would expect it to be? As I mentioned, this is the national picture, but on the next slide, I will just look across the regions for the workforce data to see what insights that might have. So at the top of the slide, it talks about the workforce benchmarking. It's not support planning for the workforce, but also provides an oversight into the retention of the current staff. Here you can see an insight into regional and organisational level. So within our adults and older people mental health census, we can compare the national average retention, that's in dark blue, with the participating organisations data in light blue, alongside directly alongside to allow for direct comparison. It can help to highlight where organisations are either failing to retain staff or conversely doing well at retention compared to the national picture, and if there's any learning or good practice that can be shared. In this example, you can see there is a 22 percentage point difference for retention of nurses in the adult mental health workforce, allowing the organisation to dig deeper into this metric and to understand the reasons behind it. At the top of the slide, I've included a quote from our 2024 participant survey, where the organisations have feedback that the importance of looking into this area of workforce. The data we've showcased here is for a small selection of our full portfolio of workforce benchmarking data that we're able to collect and analyse. Here on this slide is a list of some of the other areas we collect data in. I'd also like to draw your attention to the quote from Carol Benson around how they've used the outputs and data to assess progress, identify changes and guide their future decision making, which summarises really well what we're intending to achieve with our workforce benchmarking. As I mentioned earlier, we've got a brand new technology solution coming this year, and this is a sneak peek at some of the outputs. It will replace the electronic reports and provide organisations with the ability to view, analyse and compare their data interactively, so you'll be able to drill through our metrics to be able to see your data in comparison to other organisations in a way that you've not been able to do with the workforce data previously. Previously, we've only been able to provide you with PDF reports, so I'm hoping that this is a big improvement in the way that we can show our data, and it will help you to use the data in a much more granular fashion. And finally from me, thanks for listening, and I hope you can take away an idea of how workforce benchmarking can help you to support safer staffing and ultimately better patient care. And again, this is just a QR code so that you can look at our website or the area of our website, and I'll put a link into the chat. There's also a quote there from Steve Jones, who's the National Clinical Advisor for CYP Specialised Commissioning at NHS England, showing how valuable that they find the data. So thank you. I'll pass back to Emma now.
Lovely, thanks Janet. Hopefully a nice overview there in terms of some of the additional collections that we're currently undertaking around mental health workforce. We are a little bit ahead of time, so does anyone have any questions for Janet at this point? Haven't seen any in the chat. Sarah, can somebody help Sarah come off mute? There we go. Hopefully you can take yourself off mute now, Sarah.
There we go. Thank you. Yeah, good morning. It was just a very quick one regarding the learning disability and autism data collection. If we want to be part of that, do we just go onto the benchmarking website, and I'm assuming there'll be links or information there for us to be included in that collection?
Absolutely, and I'll put a link into the chat.
Perfect.
Yeah, so that you can get directly to that.
Excellent. Thank you very much.
Thank you.
Wonderful. And Stephen McCard is asking, when will the workforce toolkits be available?
They'll be available towards the end of the collection cycle, so at March we'll be able to publish those.
Wonderful. Thank you. Can't see any other questions in the chat or any other hands up, so thanks very much, Janet.
Thank you.
So we are going to take a break for lunch, so we will just give you a little bit longer for lunch.